given the mixed results in non-central pain conditions, how do you identify which patients are most likely to respond to LDN therapy? Are there specific clinical markers you rely on?
That's an excellent question. No, actually there isn't. I think empirically, like you said, patient psychology has a lot to do with it. How motivated they are, how engaged they are, what's been their level of compliance prior to this, and are they doing anything else, right? Like a lot of us would probably say all the cool things that we have, all the tools in our tool belt, you know, without sort of the foundational pillars of health, it's hard to budge a needle, right? It's hard to move a needle. So, you know, for non-central pain, I admittedly utilize it less, with the exception of a comorbid condition. You know, they have a neurological disorder, they have an autoimmune condition, something like that, but it's a non-centralized pain. They just happen to have Hashis or something else along with it. Then I will do it and run it in the background. I will admit, I think that I have had less luck with non-central pain, particularly mechanical pains that are isolated, than I did with central pains. That being said, with I think what you and I were talking about earlier, with new dosing strategies and new philosophies, having to take a step back and retrial patients, I think there's a place for. You know, it's been an evolution, and so when you haven't really changed appropriately, you know, I think we don't know yet is ultimately the answer. I think we have a new strategy to try, and we should be trying it. But prior to that, it's been a little hit and miss.